since if you reach 50 years old, 30 to 35% of you will become diabetic. And at any time, 40 to 60% of hospitalized patients have diabetes. So even though if you go to any subspecialty, you'll still have to deal with it. Hi, David. Can you hear me? Okay. Okay. So even if you choose different subspecialty of medicine, you still need to know how to treat diabetes. At the end of this lecture, I hope that you'll understand that there's more to the treatment of diabetes than metformin and sulfonylurea alone. The natural history of diabetes is a period of insulin resistance first, with impaired glucose tolerance tests. That constitute about 40% of the US population. And there's a phase in which insulin resistance will progressively get worse until the insulin secretion can no longer cope with the degree of insulin resistance. And when your insulin secretion is lower than what is necessary to overcome insulin resistance, you will develop overt diabetes. So how do you choose medication for treatment of type 2 diabetes? You look at the underlying physiology, pathophysiology of the patient, the severity of hyperglycemia, the degree of insulin resistance versus insulin deficiency, the presence and severity of glucose toxicity, and the degree of postprandial hyperglycemia. You also look at the overall condition of the patient, including their age. It's no use teaching an 80-year-old how to use insulin for the first time in their life unless it's absolutely necessary. Look at their existing disease. If they have severe congestive heart failure, there's no need to control the blood sugar tightly. Their lifestyle, if they're eating one big meal a day, there's no need to give them split mix insulin. And their willingness and ability to use injected medication. When you choose an oral medications for diabetes, you have to keep these clinical markers in mind. The body habitus of the patients. If they have apple-shaped body or big belly, you assume they have some degree of insulin resistance. Generally, insulin resistance increases with age, so younger patients are more likely to be insulin deficient. Weight change. If their BMI is more than 27, it's invariably associated with insulin resistance. However, if they're 300 pounds, but they have recent weight loss with hyperglycemia, you should assume that they have some degree of insulin insufficiency. So weight loss is an important marker for insulin insufficiency. The duration of diabetes, if they had type 2 for more than 10 years, it is generally associated with some degree of insulin deficiency. If they have dyslipidemia, hypertension, and gout at the same time, more likely they're very insulin resistant. And then you look at their glucose pattern. If they have fasting hyperglycemia, but lower values before lunch and before dinner, more likely their primary problem is hepatic insulin resistance. If they have postprandial hyperglycemia, meaning after meals their blood glucose go to the 200 range, they have lost their first phase of insulin release, which is typical of early type 2 diabetes. However, if they have marked postprandial hyperglycemia, meaning after meals their blood glucose is running in the 300s, 400s, their insulin deficiency is beyond the first phase insulin release, the loss of the first phase insulin release, meaning the second phase insulin release is also lost. Now, if there, this is very sensitive, I cannot move this. If their glucose values are unresponsive to oral therapy or lifestyle changes, it would suggest insulin deficiency. If their fasting glucose is more than 200 milligrams per deciliter, it would suggest absolute insulin deficiency. If their blood glucose keep on going up throughout the day, that would suggest insulin deficiency. If their blood sugar is very labile, they go out and walk and their blood sugar would drop, you should assume that they have type 1 diabetes. So the oral treatments that are available right now are the sulfonylurea, meglitinides, and D-phenylalanine derivative that acts on the pancreas, acarbose and miglitol that acts through the gut, GLP-1 agonists and DPP-4 inhibitors that act both at the pancreas and the gut and CNS level, metformin that acts through the liver, the thiazolidinedione that acts through the muscle and adipose tissue. So you have to make a choice on which one to choose first on these oral agents. Not everybody should be appropriately treated with metformin or sulfonylureas on day 1 of their hyperglycemia. So, I'm going to go briefly through this medication just to make sure that you are aware of the contraindications, because we consistently see this problem in the clinics. Metformin is actually the cheapest medication. It's the first line of treatment in most type 2 diabetic. It can reduce hemoglobin A1C by 1.5 to 1.8% depending on your starting A1C. If your A1C is 14%, it can decrease it by 5%, okay? However, if your A1C is already 8%, it will decrease it at a lower value. It has beneficial effects on lipid profiles and promote weight loss. You need to pay attention to diarrhea. Diarrhea affects 30% of people starting metformin, which generally lasts 2 to 3 weeks. That's good. You should routinely warn your patient that they will have diarrhea for the next 2 to 3 weeks, but try to live with it. And there are ways to circumnavigate this problem. You can use the XR preparation. It has less diarrheal effect. And the slow-release form, another slow-release formulation called Glumetza. However, about 5% of patients will have residual diarrhea throughout the time that they're taking metformin. I don't know how many patients with fecal incontinence that were induced by diarrhea. Half of your IBS patients will be cured if you stop their metformin. So you need to pay attention to this side effect. I have several elderly patients hospitalized several times for acute renal failure from dehydration from metformin use. And nobody ever stopped them after the third hospitalization when I saw the patient and stopped it. So be very aware of this effect, especially in elderly patients. It's a very big cause of acute renal failure in elderly patients. And it can cause subclinical reduction in vitamin B12 in 70% of the patients, so you need to check their B12 level yearly. Lactic acidosis, though, is rare, although it's the most common quoted side effects of metformin. It's just 0.03 cases per 1,000 patient years. However, you need to pay attention to this because the mortality rate is over 50% with lactic acidosis. So, in general, the contraindications are to prevent lactic acidosis. If serum creatinine is over 1.5 milligram per deciliter in males and over 1.4 milligram in female, any degree of liver dysfunction, congestive heart failure that require drug therapy, alcohol abuse or binge drinking, which is a lot of the people in the population, acute or chronic metabolic acidosis. These are the contraindications for use of metformin, and it should be temporarily withheld if the patient has acute MI, exacerbation of their congestive heart failure, severe infection, 48 hours before and after use of iodinated contrast media or major surgical procedures. The next medication is a very neglected family of oral hypoglycemic agent. If you learn about this medication, you will be a star with a lot of your patients. This is alpha-glucosidase inhibitor, acarbose or miglitol. Okay? It's a competitive inhibitor of the intestinal brass border alpha-glucosidase. This is the enzyme that will break the polysaccharides into monosaccharides, the disaccharides into monosaccharides, and only monosaccharides will get absorbed through the intestine. Therefore, it also delayed carbohydrate absorption time from the GI tract. It's not very potent. However, you have a lot of patients who come with reactive hypoglycemia, with true reactive hypoglycemia. The patients who come and tell you that I have sweaty episodes, I feel weak, I feel tired, you know, these are all pre-diabetic patients. You will cure half of your chronic fatigue patients if you pay attention to reactive hypoglycemia. It's more effective in people who consume a diet high in carbohydrate. Medication is taken with the first bite of food. And the problem here is diarrhea occurs in 60% of people taking this medication, and it has to be discontinued 15% of the time. To illustrate how this become a very big problem, reactive hypoglycemia, I just saw a patient recently who lost consciousness from hypoglycemia every 2 or 3 days. Was admitted several times to the hospital, and it's all pre-diabetic reactive hypoglycemia. This is becoming quite common in patients who has gastric bypass surgery. It's a part of the dumping syndrome. So we're now dealing with a lot with the popularity of gastric bypass surgery. We're now dealing with a lot of reactive hypoglycemia and dumping syndrome, and this is the drug of choice for the treatment of that. Sulfonylurea. Sulfonylurea. Sorry, I will not point anything anymore. Okay. Sulfonylurea. It binds to the sulfonylurea receptor in the beta cells, closing the potassium channels, leading to opening of the calcium channel and insulin release. But there are differences among the different class of sulfonylurea. Glyburide tends to bind more tightly than glimepiride or glipizide to sulfonylurea receptor. So try to avoid the use of glyburide in elderly subjects because they will be hypoglycemic for 3 to 4 days if they get hypoglycemia. Meglitinides or ripaglinide is another class of medication that we do not use enough. These are benzoic acid analogs that prime cell for glucose-dependent insulin release. And it's quite potent, but this is very useful in elderly subjects in which, especially if they're not mentally normal and you're not sure that they will eat their meals regularly on time. So they just pop a pill before each meal. So you use it with each meal. Okay, so this is very useful for patients, elderly subjects who lives alone, that you do not want to induce hypoglycemia, who may forget to eat sometimes. So meglitinides or Prandin is very useful for this purpose. Natiglinide or Starlex is another medication that's useful for mild diabetes. A lot of our cystic fibrosis patients in which they get for postprandial hyperglycemia only, no fasting hyperglycemia, Starlex is a very appropriate medication. Okay. The next class of medication are the incretin hormones. What is an incretin hormone? Any volunteer? I'm sure you all know what an incretin hormone is. If I take 50 grams of carbohydrate by mouth, my insulin level will go to 50 unit per ml. If I inject 50 grams of glucose through the IV, my insulin level will not go as high. It will be 25. I lost 50% of my insulin response through IV route. The reason is I lost the effect of the incretin hormone, GI hormone, that will increase insulin release. So these are GI hormone that increase insulin release. The first one is glucagon-like peptide 1. It's produced in the L cells in jejunum and ileum. However, it only takes for the food to reach the stomach for these L cells to be stimulated to produce this hormone. Generally, the half-life is 4 to 5 minutes, and it is metabolized by DPP4. This is the enzyme that degrades this hormone. This hormone is reduced in type 2 diabetic. Part of the reason why insulin secretion is impaired in type 2 diabetic. So when you give this hormone, it can stimulate insulin synthesis in the beta cell, increase beta cell mass. We are not sure that long-term effect may be pancreatic cancer. In animals, there seems to be evidence that it may induce pancreatic cancer or at least nesidoblastosis. It can enhance glucose-dependent insulin secretion, suppress glucagon secretion. Half of the problem in diabetes is postprandial increase in glucagon level that induce hyperglycemia. It can slow gastric emptying time, improve and reduce appetite and food intake. Sometimes this becomes a major utility for this drug. There's 2 preparations right now. Most of these are synthetic one of which exenatide was based on a salivary protein from a lizard called Gila monster, derived from lizard in the desert of Arizona. Okay, it is, these are, so GLP-1 in itself has a very short half-life. By having a 50% similarity in amino acid, you'll be able to extend the half-life of this medication. So it's injected once to twice a day, twice a day for exenatide and once a day for liraglutide. It can induce mild to moderate nausea, pancreatitis, and C-cell hyperplasia. So you need to monitor the patients for medullary cancer of the thyroid. This is actually quite useful. I've used this for patients who binge eat and are really hungry in between meals. And they seems to have a selective dislike. They develop selective dislike of food. In general, they stop eating meat in general. Okay. And then we also have DPP-4 inhibitors, sitagliptin and saxagliptin, so that you can extend the half-life of endogenous GLP-1. Pramlintide is another medication that is useful for type 1 and type 2 diabetics. It is derived from amylin, which is co-secreted with insulin in response to rising glucose. However, we cannot use amylin because it's a very sticky protein. That's part of the reason why amylin deposits in the beta cells. That's how you get the amyloid deposits in the pancreas. Therefore, it cannot be formulated commercially for injections since it's going to stick everywhere. Instead, they change a few amino acids and use it to formulate this medication called pramlintide. It acts as a neuroendocrine hormone that promotes satiety and slow gastric emptying time, and it's contraindicated in gastroparesis. I usually give it concurrent with insulin injection. Okay, so based on your knowledge, extensive knowledge of oral hypoglycemic agents, it is recommended by the American Association of Clinical Endocrinologists and the American Diabetes Association that if a patient presented with A1C of 6.5 to 7.5, you choose these therapies. If you look at this, there's no sulfonylurea here as a first choice of treatment. The reason for this is it has been found that if you use sulfonylurea early in the treatment of type 2 diabetes, you will shorten the time period for the need to switch to insulin therapy. So by almost 5 years. So it's actually not a good idea to use glipizide glyburide as your first choice for oral hypoglycemic agents. Metformin will always be the preferred initial drug therapy if you think the patient is insulin resistant. DPP-4 inhibitor if they have high postprandial and fasting glucose. GLP-1 agonists if they have very high postprandial glucose. Thiazolidinedione will be your first choice if they have metabolic syndrome or fatty liver. Alpha-glucosidase inhibitor if they have high postprandial glucose. Methiglinide if they have high postprandial blood glucose. Sulfonylurea if they have high fasting plasma glucose. So after 2 to 3 months of monotherapy, if it's not effective, you go to dual therapy. After 2 to 3 months, if it's not effective, you go to triple therapy. Then if it's still not successful, you add insulin. For subjects with A1C of 7.6 to 9%, you should start with dual therapy for the past 2 to, and then go for change it if necessary after 3 months. Okay. For subjects with A1C of over 9%, if they're symptomatic, polyuria, polydipsia, weight loss, you have to start insulin therapy at that point, okay? And just because you're on insulin therapy does not prevent you from adding oral therapy. In general, if you are already using split-mix insulin, it's not a good idea to have sulfonylurea. If you are only using basal insulin, it's okay to use sulfonylurea. You have to warn your patients routinely that even if you give the maximum dose of oral agents, it will take 4 to 8 weeks to achieve the maximum effect of each medication. So tell your patients, don't call me until 1 month later if your blood sugar is still out of control. Okay, even if you already use the highest effective dose and it's going to work, again, it takes 4 to 8 weeks for each oral agents to work. And keep in mind, when you monitor A1C, do it every 3 months anyway. The insurance company will pay only every 3 months. That's because even if you give the maximum effective therapy, if you start with A1C of 10, it's going to theoretically bring it down to 7%, in 1 month, you will only decrease it by 50%. So you'll end up with 8.5%, even though eventually it will bring it down to 7%. Now, what are the indications for insulin therapy in type 2 diabetic? High fasting blood glucose. If it's over 300, don't bother to try anything. Just give them insulin. If they have polyuria, polydipsia, and weight loss, do not try oral agents at this point. You'll get into a lot of trouble by using oral agents. Remember that there's such thing as glucotoxicity, and practically half of your patients that require insulin therapy will eventually can be taken off insulin therapy. If you are able to reverse glucose toxicity after 6 to 8 weeks of good glycemic control, you can try these patients on oral agents. And all gestational diabetic patients or type 2 diabetic patients who became pregnant has to be on insulin therapy. True insulin deficient condition like type 1 diabetic, if they have history of pancreatectomy, at least 80%, or pancreatic dysfunction, history of wide glucose fluctuation, ketoacidosis, or insulin use for more than 5 years, or history of diabetes for more than 10 years, they're more likely insulin deficient. So, remember our normal insulin secretion. There's a small amplitude of insulin secretion every 5 to 10 minutes in our body, even though we're fasting, we're sleeping, etc. And there's a larger oscillations every 1 to 2 hours. This constitutes our basal insulin secretion. When we eat, this is what we get. This is the familiar pattern that you see in a lot of textbooks is when we eat, okay? There's a first phase insulin secretion, which lasts for 0 to 10 minutes. This is the preformed insulin in the beta cells. And the second phase insulin secretion, which lasts up to an hour, is the newly synthesized insulin in the beta cells. Therefore, in general, basal insulin should constitute 50% of your insulin requirement, and bolus insulin or pre-meal is also about 50% of your insulin requirement. If you try to recall the structure of insulin, there's an alpha and a beta chains. There's a tendency for this insulin molecule to form dimers and hexamers, particularly in the presence of zinc, which is all over our body. So that's part of the reason why there's a delay in absorption of insulin from the subcutaneous tissue. The insulin analogs are all formulated to prevent this dimer and hexamer formation. So these are the amino acid substitution. Most of it are in the beta chains of insulin. For glargine, there's addition of 2 amino acid to the beta chain in addition to a change in one of the amino acid in the alpha chain. The reason glargine is a slow release form is because it's formulated in a very acidic pH 3 to 4. so that when you inject it subcutaneously, it tends to aggregate because nothing is soluble unless it is in physiologic pH. So your blood pH will, your interstitial tissue pH will eventually neutralize the acidic pH of glargine. As you neutralize it, the part that are in a physiologic pH will get absorbed. That's how they formulate it to be a slow absorption insulin. It's all pH dependent. For levetiracetam, they add a myristic acid, that's a fatty acid, that will bind to albumin. Therefore, it's circulating with albumin and slowly being released from albumin. And you try to recall, this will be part of your mix-up test question. This always come out in the board exam on the duration of action and how to change your insulin regimen based on the duration of action. So you try to mimic what is normal, which is basal insulin 50% and mealtime insulin 1/3 of the 50% with each meal. And the goal of treatment in normal people, preprandial or fasting blood glucose is less than 100, 2-hour postprandial is less than 140, and the American Diabetes Association would advise a fasting of 90 to 130 and postprandial of less than 180. There are some practical issues that you need to know about insulin. If you use a vial, which is generally about 1,000 units per vial, you can store it in refrigerator or room temperature. It should not be frozen. It can be kept at room temperature up to a month. If it's an unopened vials, you can refrigerate it and keep it until its expiration date. For open vials, you need to discard it after 28 days for most insulin. Glargine can be stored at room temperature for up to 28 days. Detimir, on the other hand, may be kept at room temperature up to 42 days. So you have to make these choices, especially in patients who are going to travel. You want to avoid exposure to extremes in temperature, less than 36 degrees or more than 86 degrees. The cartridges or pre-filled insulin, when you use it, you can no longer put it back on the refrigerator. It can be used for 4 weeks at room temperature. They cannot be refrigerated once you start using it. However, there's a difference between the single preparation versus the mixed preparation in the pre-filled syringe or the pen form of insulin. The 70 to 30 cartridges, or Novolog 7030, Humolog 7525, can be stored at room temperature for a maximum of 10 to 14 days only. So if the patient is using just a few units, you need to warn them that they cannot keep. Remember, you can no longer refrigerate it once you use those pen. Okay, once you start using it, you cannot refrigerate it, and yet you have to discard it after 10 to 14 days. You cannot use the premix one. In elderly subjects in which you have to draw their insulin and put it in the refrigerator, you should use it within 21 days, the ones that are already pre-filled in syringes. You need to rotate the injection sites to avoid focal fatty deposits, which is lipohypertrophy, or fatty wasting, lipoatrophy, or lipodystrophies in general. In terms of the rate of absorption, the abdomen is the fastest, followed by the arm, the thigh, and the buttocks is the slowest. This has practical uses. If you need to bring down the blood sugar very fast, use the abdominal area. If their insulin is not lasting long enough, try to inject it in their buttocks. You want to avoid the 2-inch radius around the navel because you're likely to hit a major artery or vein. And you need to avoid the areas close to the knees and inner thigh. Again, it's all about blood vessels. And if you hit an artery or a vein accidentally, the insulin will get absorbed in minutes instead of hours. So, how do you start insulin therapy? For people on oral agents, you could start by adding basal insulin at bedtime or long-acting insulin at bedtime. And you start at 10 units or 0.2 units per kilogram, then ask them to check their fasting blood glucose until it's less than 120. If high, and you reduce it according to the response, or increase it according to the response. Okay? So in general, a single evening insulin dose is how you initiate it, and 5 to 10 units of NPH or glargine for BMI of less than 25, or for BMI of more than 25, at least 10 to 15 units of NPH at bedtime or glargine, or 70-30 before dinner. Whenever you have short-acting, you have to give it before dinner. An alternative formula is to divide the average fasting blood glucose by 18, or divide their body weight in kilograms by 10 as a starting dose. If you need multiple injection insulin regimen, you need to keep in mind that the 24-hour insulin dose mean average requirement in type 1 diabetic is 0.5 to 0.6 unit per kilogram. In type 2 diabetic, it's 1 to 1.4 unit per kilogram. So you start at the dose. For type 1, I generally start at 0.2 to 0.5 units, or skinny people. For BMI more than 25, I usually start at 0.5 unit per kilogram, unless they're using steroids, in which case I start at 0.8 unit per kilogram. You need to be aware of the different sensitivity of the patients based on their medical condition. Normally, insulin-sensitive people, 1 unit of insulin will lower their blood glucose by 50 milligram per deciliter. If they have creatinine over 2, 1 unit can lower their blood glucose by 60 to 100 milligram. If their BMI is over 25, 1 unit can lower it by 30 milligram per deciliter. If their BMI is more than 30, 1 unit can lower it by 20. If they are severely insulin resistant, sometimes the 1 unit can decrease it by only 5 to 10 milligram. What you have to keep in mind is the strategy for treatment is first control the fasting glucose. The higher the A1C is, the more effort you need to direct in controlling their fasting glucose. Once their A1C is near normal, you need to exert more effort in controlling their postprandial glucose level. Okay. There are instances in which you need to start IV insulin, not only in DKA, critical care illness, MI, or cardiogenic shock. This is a routine for post-op period following heart surgery. NPO status in type 1 diabetic, pre, intra, and post-op care for type 1 diabetic, organ transplantation, stroke, and high-dose steroid therapy, and labor and delivery. Okay. So you need to keep in mind that whenever we're sick, our basal insulin goes up, even if we're NPO. And our nutrition, when we get it through tube feeding, it will be a much higher insulin requirement compared to PO feeding. And the correction dose, in other words, the sicker you are, the higher your insulin requirement will be. So why do we use IV insulin? Because it decreases mortality rate, sepsis, dialysis, blood transfusion, and polyneuropathy. Keep in mind, patients who are in ICU for a long time, once they're recovered, they can hardly walk, they can hardly sit up. All their muscles weakness are related to polyneuropathy. Part of the problem is you did not control their blood glucose while they're critically ill. External wound after coronary artery bypass, we need a very tight control of blood glucose primarily because it affects external wound rate of infection significantly. Again, hyperglycemia in ICU can enhance tissue injury, lower immune resistance, increase inflammation, and increase platelet aggregation. So in general, in critically ill surgical patients, we want to maintain their blood glucose between 140 to 180. While in patients who are sick but are eating, you want to maintain fasting of less than 110, postprandial blood glucose of less than 180. So how do you start IV insulin? If their blood glucose is normal at the start, when you're going to start IV insulin, their blood glucose is normal, and they have average BMI, start at 1 unit per hour. If they have high BMI, hyperglycemia, or they have more than 40 units of insulin daily requirement per day, start at 2 units per hour. Or an alternative approach is just calculate 50% of their ambulatory daily insulin dose divided by 24 and start at that rate. Or weight-based approach at 0.02 units per kilogram per hour. In general, even if their blood sugar is still 600, if you are infusing at more than 10 units an hour, that's the maximum effect you can achieve. It's not going to be any different if you infuse it at 30 units an hour, because at 10 units an hour, you get the maximum effect that you could possibly get from IV insulin. You have to switch to other type of therapy. And then blood glucose has to be checked every hour until it's stable for 6 to 8 hours, and then you can do it every 2 to 3 hours. In general, you do not want the nursing staff to use a formula and calculate the IV insulin because there's high incidence of accident from it. So generally, you have this, you encircle this first column if you don't know the patient, and then 6 to 8 hours later, if it's not working, you switch to the second column. Don't wait for 24 hours. You will leave the patients on hyperglycemia for a long time if you wait for the next day. In terms of subcutaneous insulin in the hospital, you still need basal insulin even if they're NPO, especially if they're type 1 diabetic. When you do the prandial insulin, you need to consider their food intake, their IV dextrose, their TPN dose, their enteral tube feeding, and their nutritional supplement. So, what you have to keep in mind is how to start subcutaneous insulin in the hospital. Are they eating? Are they eating enough carbohydrate? Are they on continuous tube feeding? Therefore, they're exposed to carbohydrate all the time. Are they post-op, especially if it's a GI surgery? Therefore, they will not be eating full meal. Are they eating only during the day and getting overnight enteral tube feeding? So this is how you give insulin in the hospital. If they're eating properly, 3 meals a day, 50% basal, 50% into pre-meals. If they know how to do carb counting, generally most people will eat more at dinner time, so you give higher dose of preprandial insulin at dinner time. So this is how you do calculate for carbohydrate counting. Most of your type 1 diabetic patients are familiar with this. One serving of carbohydrate is 15 grams of carbohydrate. That's really not much food. So you can have 2.5 inch, one biscuit which should be 2.5 inches across. One slice of white bread, half cup of cooked cereal or dry cereal, 10 to 12 chips, half cup of corn, in general, half cup of corn, half cup of pasta, half cup of rice. Okay, so that's how you count the carb for most patients. One medium-sized roll, etc. 1 6 to 7 inch tortilla. So that's one carbohydrate serving. In general, most diabetic, you would advise 40 to 60 grams of carbohydrate per meal. The minimum per day is 130 grams primarily because the brain requires glucose. So you should not deprive your patients, your diabetic, cut down on carbohydrate. That's not an eating strategy for these patients. And in terms of fruits, again, there's limited amount. For example, 10 grapes is 1 serving of carbohydrate, so I just routinely tell patients that. And 1 kiwi, you know, and most of the time, let's see, let me look for apple. Yeah. Apple actually, it has to be a small apple for 1 serving of carb. Banana is you can hardly find small banana. So the large banana is half of the banana is 1 serving of carb. Okay. If the patient is undergoing anesthesia and they're type 1 diabetic, if their general anesthesia lasts for less than 1 hour, chances are they'll be able to eat dinner because the nausea and vomiting will be less. So you give their usual glargine dose. Usually I just give 80% of their basal rate and then give their usual dinner dose. If they undergo prolonged general anesthesia of over an hour, if the procedure is long, it's better to give them IV insulin. If they are on tube feeding, actually my favorite regimen, the easiest way to treat this patient is to give NPH every 6 hours and give regular or Novolog insulin every 6 hours. About 70% will be NPH, 30% will be regular insulin. Or you can give glargine and then every 6-hour dose of regular insulin. If they are on TPN or IV dextrose infusion, look at the bottle and look at the carb. You start at 1 unit per 10 grams of carb. In general, for TPN, 70 to 80% of the insulin has to be in the TPN bag, but about 20 to 30% you have to give it subcutaneous, because if you overdo it on the TPN, you have to get rid of the whole bag, which is very expensive. So in general, you just aim for 80% of the insulin goes into the TPN bag. If they are getting high-dose steroids, it depends on the type of steroids. If they're getting prednisone, you know that it's short-acting, so most of the effect are during the day. So you will give a lot of the preprandial insulin. It's no longer a 50% division. Your basal will go down significantly to 30% of their insulin requirement, and 70% will now be prandial insulin. Again, there's a difference between prednisone versus dexamethasone. Okay. Now, if you are not familiar with the patients and you get a call at 3 a.m. that the patient has blood glucose of 600, how much insulin will you give? Any volunteer? You don't know the patients, and the nurse call you that the patient's blood glucose is 600. Everybody say, huh? Yeah, how much are you going to give the patient's insulin? Oh, the patient weighs 50 pounds, 70 pounds. Okay. Any guess? Blood glucose of 600. How much insulin are you going to give? You don't know the patient. You're on call. Swati. Sorry. What is it? Yeah, they're type 1 diabetic patients. We get called all the time for this problem. Okay.
1 unit brings it down to like 50 milligrams per deciliter, deciliter. So if it's 600, my goal is 300, I would give like 6 units.
Yeah, that's very logical, okay? But you don't know the patients. That's the key. Some patients, 1 unit can bring it down by 200, okay? So you have to go by this rule, the 1600 to 2200 rules. What does this mean? This is useful for patients that you don't know. Assume 1600, okay? If they call you for blood glucose of 600, ask the nurse, what is their usual insulin dose? If it's 20 units a day, you just divide 1600 by 20, you assume that 1 unit will decrease by 80. So the most important information you need is how much insulin does the patient is getting per day. That's the clue to their insulin sensitivity. And you use the 1600 rule to divide it by that total units of insulin per day, so that you can calculate that how much insulin to give. You don't know how many patients we have that in which they have blood glucose of 600. The internist will call for 10 units of insulin. The next time you get a call, the patient is in hypoglycemic seizure. So if you don't know the patient, you need to at least ask for their total insulin requirement in 24 hours. That's the way to decide on how much insulin to give. Okay. A caution on subcutaneous therapy: if they have low albumin, they're edematous, hypotensive, and or are on pressors treatment, they will not absorb their subcutaneous insulin properly, and the absorption rate is erratic. Therefore, you can accumulate a lot of insulin if you give it every 4 hours. Eventually, they'll all get absorbed at the same time, and you get a lot of hypoglycemic effect. In terms of hypoglycemia treatment, if the patient is alert, eating, and their blood glucose is less than 70, you give them 15 grams of carbohydrate PO, or a 4-ounce juice, okay? If the patient is alert and their blood glucose is less than 50, you give them at least 30 grams of carbohydrate, 2 juices. If the patient is not alert or is NPO and their blood glucose is less than 70, give 1 vial of D50 push. And recheck blood glucose every 20 minutes. The nurses will check it every 5 minutes and call you every 5 minutes. So you need to give instruction that it has to be rechecked in 20 minutes and retreat using the above protocol if their blood glucose is still less than 70. And provide a snack or meal within an hour after correction of hypoglycemia. For patients on continuous tube feeding, if suddenly the tube feeding has to be interrupted, for short interruption, 1 to 2 hours of interruption, start D10 water at the same rate as their tube feeding. For longer interruption, greater than 2 hours, you can even give the D10 in advance, okay, before they go for procedure. For longer interruption, more than 2 hours, you give the D10 for as long as it takes to finish, depending on what insulin you have injected. You need to be aware that because of the high incidence of obesity, we now use a lot of the U500 preparation. This is the super concentrated insulin. The reason is it decreased the volume of injection. Although it's humulin R on the U500, it does not act like the short-acting humulin regular insulin like this. Instead, it acts like NPH because of the zinc, the hexamer formation, the dimer formation, much more if they're super concentrated. So it acts like a slow intermediate release form of insulin. So how do you convert a patient from U100, our usual preparation of insulin, to U500? If they're requiring 150 to 300 units of U100 insulin, you split it into 50-50 as U500 or 60-40 before breakfast, 60%, 40% before dinner. Or you can split it to 3 times a day at 33% before each meal. If their requirement is 300 to 600 units of insulin, you can do 3 times a day before each meal split, or you can add another 10% of it at bedtime. If it's more than 600 units per day, which is now becoming more common, you make it 30% before breakfast, 30% before lunch, 30% before dinner, and 10% before at bedtime. In general, we can use the usual U100 insulin syringe. There's no special insulin syringe for the U500. So, if you have 5 units of insulin drawn in the usual insulin, it's equivalent to 25 units. However, most hospital or VA system, Jewish hospitals, would require tuberculin syringe. They do not allow U500, the American Society of Pharmacology, do not allow U500 to be stored in the nurse's station because of the possibility of confusion and inducing a lot of hypoglycemia. Therefore, every dosage of U500 is drawn by the pharmacist and sent to the floor. And these are the equivalent in terms of tuberculin syringe. Essentially, just add a 0.0 to the U100 syringe. Again, in summary, you have more choices than metformin and sulfonylurea for type 2 diabetic. You need to think of the pathophysiology. Is it an insulin deficiency or primarily an insulin-resistant problem? Do not stick with metformin when the patient has a lot of GI symptoms. As I said, half of your irritable bowel syndrome will be cured if you stop their metformin. Again, sulfonylurea should not be the first choice for oral hypoglycemic agents primarily because it can shorten the time period for insulin requirement injection. And lastly, you need to check their A1C, every hospitalized patient. If it's less than 5.2, it's most likely a stress-induced hospital hyperglycemia or surgical hyperglycemia. If it's more than 6%, their A1C, they would be needing outpatient follow-up for eventual treatment of their diabetes. Any question? Yes.
I have 3 questions for you. The first one is, can you explain the rationale behind BID Lantus? I've never understood that.
The usual, remember the way Lantus become a slow-release form is pH-dependent, right? However, in a lot of type 1 diabetic, it does not last as 24-hour preparation. About 40% of type 1 diabetic would require BID injection, primarily because it does not last for 24 hours. So you'll end up, if you give it as HS preparation, you'll end up with pre-supper hyperglycemia. So generally, we split it in type 1 diabetic, and we also split it in type 2 that have very high insulin requirement.
My second question is about drinking juice. Can diabetics drink juice?
Juice?
Yes.
Yeah, it's 4 ounces is 15 grams of
So
carbohydrate.
they're allowed to, because I've heard from other attendings that you shouldn't give them juice. So I just wanted to know from you.
No, you can give them juice. That's the quickest way to correct their hyperglycemia, hypoglycemia.
I'm not talking about like if they're
Oh, for their meal.
Yes, for their meal.
Yeah, they can, but it's a, it's a short, it will get absorbed quickly, and it's 1 pound of carb serving for every 4 ounces. You'd rather have them eating complex carbohydrate that will not elevate their blood glucose immediately compared to juice.
And my last question, I'm sorry, is when you start, if someone is on an oral hypoglycemic and you're starting insulin, I was unclear on how do you dose that. Do you dose it just like if you were using insulin as monotherapy, or?
Yeah, the best way to do that is to start with the HS once a day basal insulin to see if you can minimize the frequency of injection. Actually, that basal insulin is very effective. Almost 80% of your type 2 diabetic do not require frequent injection. They just need 1 shot at bedtime. And in general, you want to give them the long-acting at bedtime because it decreases their insulin requirement. If you use Lantus at bedtime versus Lantus in AM, your Lantus dose will be much higher in AM compared to HS because of the hepatic gluconeogenesis suppression effect. So, any more questions? Anybody awake?
In your tube-feeding slides, I'm tempted to use just simply Lantus for my tube-feeding patient, but getting a stable dose of nutrition and just give them a stable basal dose. But that's, according to your slide, it's not going to work.
Yeah, it generally does not work, except if they have a lot of endogenous insulin secretion and they're that type 2 that's bordering, you just push them with tube feeding. Then usually I start with BI.